Respiratory system's main job is to deliver oxygen to the body tissues while removing carbon dioxide as a waste product. This module begins by reviewing common word parts related to the respiratory system that can help you understand and construct the meaning of respiratory terminology. Additional terms that cannot be easily broken down into word components will be explained within the context of respiratory anatomy and physiology, along with common respiratory diseases and disorders. This chapter will also introduce medical specialists, some diagnostic tests, procedures, and equipment associated with the care of the respiratory system. All right, let's walk through the lower respiratory system together. If you've ever taken care of a patient struggling to breathe, you already know how quickly respiratory problems can turn into life-threatening emergencies. So, understanding how the system is built and how it works is absolutely essential. Let's start with a quick terminology piece here. The root, P-H-O-N, or phone, refers to sound or voice. When you hear the medical term dysphonia, it literally means difficulty producing sound. In other words, difficulty speaking. Patients with dysphonia might sound hoarse, weak, or strained. Sometimes it's something simple like vocal cord irritation. Other times it can point to neurological problems, airway inflammation, or trauma to the larynx. The point is, even a word like dysphonia tells us something about the underlying physiology if we understand the components of the term. Now, let's move a little farther down the airway into what we call the lower respiratory tract. This includes the trachea, bronchi, bronchioles, alveoli, and the lungs themselves. First up, the trachea. The trachea is essentially the main airway highway that carries air from the upper airway down toward the lungs. Structurally, it's made of stacked C-shaped rings of cartilage. Think of these rings like support beams in a tunnel. They keep the airway open so it doesn't collapse when you inhale. These cartilage rings are connected by dense connective tissue, which allows the trachea to stretch slightly as we breathe in and out. At the same time, the cartilage maintains enough rigidity to keep the airway patent. Patent meaning open. Without that support, every time you generated negative cell pressure during inhalation, the airway could potentially collapse. But the trachea isn't just a hollow tube. It's lined with cilia and mucus-producing cells. This is a part of the body's defense system. The mucus traps dust, bacteria, and debris, while the cilia acts like a microscopic conveyor belt that move mucus up and out towards the pharynx. From there, it can either be swallowed or expelled. In other words, your airway is constantly cleaning itself. Now, this is where things can become dangerous. If the upper airway becomes obstructed, whether from swelling, mucus, or a foreign body, air can't reach the lungs. When that happens, it becomes a life-threatening emergency very quickly. In severe situations where the airway above the trachea is blocked, one option is a tracheostomy. That's a surgical incision made directly into the trachea to create an artificial airway opening. This is within the scope of practice of paramedics. It bypasses the obstruction and allows the air to reach the lungs. In the pre-hospital setting, you may or may not perform surgical tracheostomies, but for the most part, it depends upon what your protocols are. Now let's move farther down. At the bottom of the trachea is a structure called the carina. This is where the trachea splits or bifurcates into the right and left primary bronchi. The bronchi are the major airway passages that enter each lung. The carina itself is incredibly sensitive. It contains specialized nerve endings that trigger a powerful cough reflex if something touches it, something like food or a foreign object. That reflex is protective. It's the body's attempt to forcefully expel anything that doesn't belong in the airway. Once the bronchi enter the lungs, they begin to branch repeatedly, again and again and again, forming what we call the bronchial tree. By the time that this branching process is finished, the airway is divided roughly 26 times. The structure really does resemble the branches of a tree spreading out throughout the lungs. As the branches become smaller, they eventually form structures called bronchioles. These are the smallest airways before we reach areas where gas exchange actually occurs. Bronchioles are different from the larger bronchi in an important way. They no longer contain cartilage. Instead, their walls are mostly made up of smooth muscle. That means that these airways can constrict or dilate, changing the amount of airflow reaching different parts of the lung. This is where many respiratory diseases cause problems. For example, bronchospasm occurs when the smooth muscle in these airways suddenly tightens, narrowing the airway and restricting airflow. Patients with asthma experience this type of bronchial constriction. Another related term is bronchitis, which simply means inflammation of the bronchi. When the bronchi become inflamed, they produce excess mucus and airflow becomes obstructed. A bronchoscopy is a procedure in which a specialist inserts a flexible tube with a camera into the airway to visually examine the bronchi. This allows physicians to look for tumors, foreign bodies, bleeding, and other abnormalities. Throughout the trachea, bronchi, and bronchioles, the lining contains mucus. When patients cough this mucus up through the mouth, we refer to this as sputum. Now we arrive at one of the most important structures in the entire respiratory system, the alveoli. Alveoli are tiny grape-like sacs at the end of the bronchioles. If you were to zoom in on the lungs microscopically, you'd see millions of these tiny sacs clustered together. This is where the real magic happens, gas exchange. The walls of the alveoli are incredibly thin and elastic. Oxygen moves from the air outside your body into the alveoli, into the bloodstream, where carbon dioxide moves from the blood into the alveoli to be exhaled. Because there's so many alveoli, the lungs create a massive surface area for this exchange to occur. The alveoli also produce a substance called surfactant. Surfactant is slippery and reduces surface tension inside the alveoli. Without it, the alveoli would collapse during exhalation and become very difficult to open. When alveoli do collapse, the condition is known as atelectasis. Atelectasis can cause portions of the lung to stop participating in gas exchange, leading to hypoxia if severe enough. Now, let's zoom back out and talk about the lungs themselves. The lungs connect to the trachea through the primary bronchi that we mentioned earlier. They sit inside of the thoracic cavity and rest on the diaphragm, the major muscle responsible for breathing. The top portion of the lung is called the apex, while the bottom portion resting near the diaphragm is called the base. Interestingly, the lungs are not identical. The right lung has 3 lobes, superior, middle, and inferior, while the left lung only has 2, superior and inferior, because space is taken up by the heart. That indentation where the heart sits is called the cardiac notch. Each lobe receives its own bronchial branch and contains smaller subdivisions that allow air to reach every portion of the lung. You'll also encounter the word roots pneum, P-N-E-U-M, or pneumon, P-N-E-U-M-O-N, both referring to air or lungs. For example, pneumonia literally refers to a disease condition of the lung, typically caused by an infection. Finally, we need to talk about the pleural membranes because they play a critical role in breathing mechanics. There are 2 layers. The visceral pleura sits directly on the surface of the lungs. The parietal pleura lines the inside of the chest cavity. Between these 2 layers is the pleural cavity, which contains a small amount of pleural fluid. This fluid helps to reduce friction as the lungs expand and contract during breathing. It can also help keep the lungs adhered to the chest wall, which is important for maintaining lung inflation. If fluid builds up in that space, the condition is called a pleural effusion. Excess fluid can compress the lungs and impair ventilation, which is something we often encounter in patients with heart failure, infection, or trauma. So when you take a step back and you look at the whole system, from trachea to bronchi to bronchioles to alveoli, you start to see a beautifully engineered structure designed for one critical job: moving oxygen into the body and removing carbon dioxide. All right, let's shift gears and talk about the physiology of the respiratory system. In other words, how this whole system actually works. Understanding the anatomy is important, but the real question for us as clinicians is, how does the body move air, exchange gases, and keep tissues oxygenated? At its core, the respiratory system has one primary mission: gas exchange. That means a constant supply of oxygen to the body while removing carbon dioxide, which is a waste product of cellular metabolism. Every cell in your body depends on this process. If it fails, the clock starts ticking downward very quickly. To make gas exchange possible, the respiratory system must first move air in and out of the lungs. That mechanical movement of air is called ventilation, what we simply refer to as breathing. Now, let's start with the mechanics of breathing. When you inhale, also called inspiration, several things happen almost simultaneously. The most important muscle involved is the diaphragm. When the diaphragm contracts, it moves downward and flattens. That movement increases the size of the chest cavity. At the same time, the intercostal muscles, which sit between the ribs, contract and pull the rib cage slightly outward and downward. Together, these actions expand the thoracic cavity, the space inside the chest that houses the lungs, heart, and major vessels. Now, here's a key concept. Pressure drives airflow. As the thoracic cavity expands, the pressure inside the lungs drops below atmospheric pressure by about 5 millimeters of mercury. Nature hates pressure differences, so air rushes in from the outside environment to equalize things. Air will always move from a high pressure to a low pressure, and that pressure gradient is what fills the lungs with air. That's inhalation. Now, when you exhale, also called expiration, the process reverses. The diaphragm relaxes and moves back upward. The rib cage returns to its resting position. The thoracic cavity becomes smaller again. When that happens, pressure inside the lungs increase again by about 5 millimeters as compared to the pressure outside of the body. Air is then pushed out of the lungs back into the environment. In a normal, relaxed breathing, this process is largely passive. The lungs and their chest will simply recoil back into their resting position. But breathing can become more active. During exercise or whatever the body needs more oxygen, breathing becomes deeper and faster. This is sometimes referred to as forced breathing or hyperpnea. In these situations, additional muscles called accessory muscles help expand the chest even more. You'll also see these accessory muscles being used in patients who are struggling to breathe. When someone is in labor breathing, the body recruits every muscle it can to try to move the air. Now, when we assess breathing in our patients, one of the simplest but most important vital signs we measure is respiratory rate. Respiratory rate is simply the number of breaths taken per minute. In a healthy adult, the normal range is about 12 to 20 per minute. Infants breathe much faster, often between 30 and 60 breaths a minute, because their metabolic demands are higher. As children grow older, that rate gradually slows down. Changes in the respiratory rate can be an early indicator that something is wrong. The suffix pnea or nea refers to breathing, and you'll hear it used in several clinical terms. Tachypnea means rapid breathing. Bradypnea means slow breathing. Hypopnea means shallow or reduced breathing. And apnea, well, that's the worst of all. That's no breathing at all. And lastly, dyspnea, a term we hear all the time in medicine, simply means difficulty breathing. But here's something interesting about how breathing is controlled. You might assume that the body breathes faster when oxygen levels drop. That seems logical, right? But surprisingly, the primary driver of breathing isn't oxygen. No, it's carbon dioxide. The respiratory control centers located in the medulla oblongata and pons in the brainstem constantly monitor the chemistry of the blood. They receive information from chemoreceptors located both in the brain and in major arteries like the carotid arteries and the aortic arch. When carbon dioxide levels rise, the blood becomes more acidic. These chemoreceptors detect the change and signal the brain to increase both the rate and the depth of breathing. The body essentially speeds up ventilation to blow off excess carbon dioxide. When carbon dioxide levels drop too low, the opposite happens. Breathing becomes slower and more shallow in order to retain carbon dioxide. When breathing becomes excessively rapid and deep, we call it hyperventilation. When breathing becomes too slow or shallow, we call it hypoventilation. Once air reaches the alveoli, the next critical step occurs: gas exchange. Ventilation simply moves air in and out, but respiration is a process where oxygen and carbon dioxide actually move between the lungs, the blood, and the tissues. In the lungs, this process is called external respiration. Oxygen from the air inside the alveoli diffuses across the thin alveolar membrane and enters the blood within the pulmonary capillaries. At the same time, carbon dioxide diffuses out of the blood and into the alveoli so it can be exhaled. This movement happens through a process called diffusion, which simply means molecules move from areas of higher concentration to areas of lower concentration. Once oxygen enters the bloodstream, most of it doesn't stay dissolved in the plasma. Instead, it binds to a protein inside the red blood cells called hemoglobin. Hemoglobin acts like a transport vehicle. The more oxygen attached to hemoglobin, the brighter red the blood appears. This oxygen-rich blood travels through the pulmonary veins to the left side of the heart, where it's pumped out through the aorta and delivered to tissues throughout the body. At the cellular level, another form of gas exchange occurs called internal respiration. Oxygen leaves the systemic capillaries and diffuses into the body cells where it's used to produce energy. Carbon dioxide, the waste product of that process of metabolism, moves back into the blood to be transported to the lungs. If oxygen delivery to tissues becomes inadequate, that condition is known as hypoxia. Healthcare providers commonly assess oxygenation using pulse oximetry. A pulse oximeter estimates how much hemoglobin in the blood is carrying oxygen, what we call oxygen saturation. In healthy individuals, that number usually falls between 90 and 100%. But oxygenation depends on two critical components: ventilation and perfusion. Now, we've already talked about ventilation, the movement of air into and out of the lungs. The second piece is perfusion, which simply refers to blood flow. In the lungs, perfusion occurs through the pulmonary circulation. Deoxygenated blood leaves the right side of the heart through the pulmonary arteries and travels into the lungs. These vessels branch into smaller and smaller capillaries that surround the alveoli. In the lungs, perfusion, again, occurs through pulmonary circulation, not to be confused with cardiac circulation. Together, the alveoli and the surrounding capillaries form what we call the respiratory membrane. That's the incredibly thin barrier where oxygen and carbon dioxide exchange takes place. Once oxygen binds to hemoglobin, oxygen-rich blood travels through the pulmonary veins back to the heart. From there, it's pumped out to supply the entire body. When ventilation or perfusion becomes impaired, serious problems can begin to develop. For example, pulmonary edema occurs when fluid accumulates in the alveoli. This often happens in conditions like heart failure. When the alveoli fill with fluid, oxygen can't easily cross the membrane into the bloodstream. Carbon dioxide removal becomes impaired as well. The result is hypoxia, and often hypercapnia, which is an elevated level of carbon dioxide in the blood. Without rapid treatment, those conditions can become life-threatening. So when you look at the respiratory system as a whole, and this is the way you should, it's an elegant partnership between airflow, lung mechanics, blood flow, and cellular metabolism. When everything works together, oxygen delivery and carbon dioxide removal happens seamlessly. But when even one part of that system fails, the body quickly reminds us just how critical breathing really is. Okay, so let's move into some of the common diseases of the respiratory system. This is where the anatomy and physiology we've talked about starts to matter in a very practical way. Because once the system gets disrupted, the patient can go downhill fast. And as you know, respiratory complaints can go from, I don't feel so great, to this is a true life and death emergency in a hurry. Trust me, the lungs do not like being ignored. Let's start with allergies. An allergy occurs when the immune system overreacts to something that is usually harmless. That substance is called an allergen. The body basically misidentifies it as a threat and mounts an immune response. Depending on where that response occurs, the patient may have developed inflammation of the skin, nasal passages, sinuses, airways, or even the digestive tract. Now, the severity of allergic reactions can vary a lot. Some people have mild seasonal symptoms and feel miserable for a few days. Others can progress to full-blown anaphylactic reaction, and that is a true life-threatening emergency. A common example is allergic rhinitis, rhinitis, or what most people call hay fever. These patients may have sneezing, watery eyes, itching, a runny nose, and general misery that makes them look like that they've been personally offended by a field of pollen. Food allergies can be more serious, causing tingling in the mouth, swelling of the lips or tongue, hives, and in some cases, airway compromise. Insect stings and medication allergies can do the exact same thing. That brings us to anaphylaxis. Anaphylaxis is a severe systemic allergic reaction that can rapidly become fatal if it's not recognized and treated. The patient may have hypotension, severe shortness of breath, a rash, lightheadedness, nausea, vomiting, a rapid weak pulse, or even loss of consciousness. The big problem here is that the body is reacting everywhere at the same time. The airway can swell, bronchospasm can occur, vascular tone is lost, and perfusion begins to collapse. That's why epinephrine is so important. It helps to reverse bronchoconstriction, supports blood pressure, and buys us time. And in anaphylaxis, time matters. This is not the moment for slow philosophical reflection. This is the moment to act. Now, let's talk about asthma, which is one of the most common chronic respiratory disorders you will encounter. Asthma is characterized by airway inflammation, edema, bronchospasm, and often increased mucus production. So the patient is not just dealing with one problem, they're dealing with swollen airways, narrowed airways, and secretions that can further obstruct airflow. That combination makes it difficult for air to move, especially on exhalation. Asthma attacks can range from mild to severe. Some patients quickly improve with their prescribed inhaler. Others become critically ill and may present with severe dyspnea, cyanosis, anxiety, wheezing, or in the worst cases, decreasing breath sounds because airflow has become so poor that little air is moving at all. This, my friends, is a dangerous patient. Common triggers include dust, pollen, pet dander, mold, tobacco smoke, respiratory infections, exercise, and stress. In other words, the whole world is full of things that can make an asthmatic patient unhappy. Many asthma patients are asymptomatic between attacks, which sometimes fools people into underestimating how severe this disease can be. But understanding asthma absolutely can be fatal. Treatment often includes bronchodilators delivered by metered dose inhaler, dry powder inhaler, or a nebulizer, along with other medications depending on the severity of the disease. Now, let's mention the impact of secondhand smoke because it does matter. Exposure to secondhand smoke increases respiratory illness in non-smokers and is particularly harmful in children. Kids exposed to smoke in the home have higher rates of lower respiratory airway infections, more hospitalizations, worsening asthma symptoms, more ear infections, and a higher risk of sudden infant death syndrome. So, smoking by the window is not the magical protective spell that some people think that it is. Now let's move on to the common cold. The common cold is a viral upper respiratory infection. It affects the upper airway and is usually self-limited. Symptoms typically include a runny or stuffed nose, sore throat, cough, congestion, sneezing, mild headache, low-grade fever, and just being tired. Most patients recover in about a week to 10 days, although smokers often take longer. This becomes clinically important because the symptoms of a cold can overlap with influenza and COVID-19, and symptoms alone are often not enough to distinguish them with certainty. That brings us to COVID-19 and influenza. Both are contagious respiratory illnesses, but they are caused by different viruses. COVID-19 is caused by the virus SARS-CoV-2, while influenza is caused by the influenza virus. Both can produce fever, cough, sore throat, congestion, fatigue, and body aches. Because the symptom overlap is significant, testing may be needed when the diagnosis matters for treatment. Influenza is especially important because while many patients recover, some develop serious complications like pneumonia. High-risk groups include older adults, young children, pregnant patients, and those with chronic medical conditions like asthma, diabetes, or heart disease. This is why annual vaccination is highly recommended. Next is cystic fibrosis. Cystic fibrosis is a genetic disorder that affects both respiratory and digestive systems. These patients produce thick, sticky mucus that clogs the airway, traps bacteria, and increases the risk of recurrent infections and progressive lung damage. It also affects the pancreas, interfering with the digestive enzyme delivery and causing problems with nutrient absorption. This is one of those diseases where the patient is fighting a chronic battle on multiple fronts. Breathing is harder, infection risk is higher, and nutrition may become a challenge. Now, let's talk about lung cancer. Cancer is uncontrolled cell growth, and when it begins in your lungs, we call it lung cancer. One of the most frustrating aspects of lung cancer is that patients often have no symptoms early on. By the time the symptoms show up, the disease may already be advanced. Symptoms can include a persistent or worsening cough, chest pain, shortness of breath, wheezing, coughing up blood, fatigue, unexplained weight loss, repeated pneumonia, and enlarged lymph nodes in the chest. The number one risk factor is, you guessed it, cigarette smoking. After smoking, the second leading cause of lung cancer in the United States is radon exposure. Radon is colorless, odorless, and tasteless, which is exactly the kind of thing humans tend to ignore until it becomes a problem. Treatment may involve surgery, chemotherapy, radiation, immunotherapy, or targeted therapy depending upon the type and stage of the lung cancer. And finally, let's talk about pneumonia. Pneumonia is an infection of the alveoli and can be caused by bacteria, viruses, or fungi. The alveoli may fill with inflammatory fluid and purulent secretions which interferes with gas exchange. That's why these patients often present with cough, fever, chills, dyspnea, rapid shallow breathing, and chest pain, along with fatigue and sputum production that may be yellow or green. Now, there's different types of pneumonia, and the classification matters. Aspiration pneumonia occurs when food or liquid enters the lungs. Community-acquired pneumonia develops outside the hospital. Healthcare-associated pneumonia is linked to healthcare exposure, and ventilator-associated pneumonia occurs in patients on mechanical ventilators. As clinicians, the big takeaway is this: respiratory disorders may look similar at first, but the underlying problem can be very different. Some involve inflammation, some involve infection, some involve obstruction, some involve allergic responses. Our job is to recognize what is happening, how severe it is, and how quickly the patient may deteriorate. Because when the respiratory system begins to fail, the body does not send a polite memo. It sends a crisis. Okay, let's talk about some of the common respiratory equipment that you're going to see both in home care and acute care settings. As with most things in respiratory care, the equipment itself is not the point. The point is understanding what problem it is solving. If you know that, the device can make a lot more sense. Let's start with CPAP. CPAP stands for Continuous Positive Airway Pressure. This device is used for patients who are still breathing on their own but need help keeping their airway open. The classic example is a patient with obstructive sleep apnea. These patients are capable of spontaneous breathing, but while they sleep, the soft tissues of the upper airway can collapse and obstruct airflow. A CPAP machine uses a mask that fits over the nose and sometimes both the nose and the mouth, and it delivers a constant level of positive pressure throughout the respiratory cycle. That steady pressure acts almost like an air splint, helping to hold the airway open so it does not collapse during sleep. That's the key concept with CPAP: one continuous pressure. The patient breathes spontaneously, but the machine provides ongoing support to maintain airway patency. Now, from a patient comfort standpoint, CPAP can be very effective, but not everyone loves it. Shocking, I know. Apparently, sleeping with a pressurized mask strapped to your face is not universally described as relaxing. But for many patients, especially those with sleep apnea, it can dramatically improve sleep quality, reduce daytime fatigue, and decrease the physiological stress caused by repeated episodes of apnea. Now let's compare CPAP to BiPAP. BiPAP stands for Bilevel Positive Airway Pressure. Like CPAP, it is also used to support patients who are breathing on their own and need help maintaining airway patency or improving ventilation. But unlike CPAP, BiPAP provides two different pressure settings. There is a higher pressure during inhalation and a lower pressure during exhalation. Now that difference matters a lot. Because the pressure drops during exhalation, many patients find BiPAP more comfortable than CPAP. They don't have to exhale against the same constant pressure the whole time. In the home setting, this can make BiPAP more tolerable for some patients with obstructive sleep apnea. In the acute care setting, BiPAP becomes even more important. It's often used for patients in acute respiratory distress as a non-invasive alternative to intubation and mechanical ventilation. In other words, it can help support ventilation and reduce work of breathing without immediately having to place an endotracheal tube. That is a big deal. If a patient is tiring out, struggling to breathe, or showing signs of impending respiratory failure, BiPAP may help to improve gas exchange and buy time while avoiding more invasive airway management. Of course, that depends on the patient being able to tolerate the mask, protect the airway, and cooperate with the therapy. A combative vomiting patient and a tightly sealed mask are generally not a match made in heaven. Now let's move to a much simpler device, the nasal cannula. The nasal cannula is probably the most familiar oxygen delivery device in medicine. It consists of oxygen tubing attached to two prongs that sit in the nostrils. It's simple, lightweight, easy to apply, and commonly used both in hospital and out of hospital. A nasal cannula is best suited for patients who are relatively stable and need low flow supplemental oxygen. It does not provide ventilatory support. It does not generate positive pressure. It simply delivers additional oxygen. This makes it really useful for patients with mild hypoxia, chronic lung disease, or those who have a little extra oxygen support needed without more aggressive intervention. It's often used with patients who have COPD, chronic obstructive pulmonary disease, although as always, the device choice depends on the patient's actual clinical picture rather than just the diagnosis label slapped on the chart 3 years ago. One of the reasons nasal cannulas are so popular is that they're generally well tolerated. Patients can talk, eat, and interact while wearing one. Now, it's not perfect, but for many stable patients, it does exactly what it needs. Now let's talk about pulse oximeter, which is not an oxygen delivery device, but is absolutely essential respiratory equipment. A pulse oximeter is a portable device used to estimate a patient's oxygen saturation, often written as SpO2. It's usually placed on the finger, although other sites can be used in certain circumstances. The device works by passing an infrared light through the tissue and analyzing how much of the hemoglobin is carrying oxygen. It also provides a pulse rate. In a patient without significant underlying respiratory disease, a normal pulse oximetry or pulse ox reading is typically around 90 to 100. Now, this is where students sometimes get themselves into trouble. The pulse ox is helpful, but it is not the whole patient. A normal oxygen saturation does not automatically mean that the patient is fine. Likewise, an abnormal reading does not mean that the machine is right. Poor perfusion, motion artifact, nail polish, cold extremities, shock states, carbon monoxide poisoning, and equipment issues can all interfere with the reading. So, yes, use the pulse oximeter, absolutely, but do not worship it. It is a tool, not a tiny glowing prophet clipped onto the patient's finger. Also remember that pulse oximetry tells us about oxygenation and not necessarily ventilation, two very different and very important concepts. A patient may have a decent O2 sat for a while and still be ventilating poorly, retaining carbon dioxide and headed towards respiratory failure. This is why patient assessment still matters. Let me say that to you again. This is why patient assessment still matters. Work of breathing, mental status, respiratory rate, lung sounds, skin signs, and overall presentation all have to be considered. As you step back and look at the respiratory system as a whole, from the anatomy of the airway to the mechanics of breathing, gas exchange, and the diseases that regulate it, you begin to see how tightly coordinated this system really is. Every breath depends on the proper function of the airways, lungs, blood flow, and the nervous system that regulates it all. When any one of these pieces fail, oxygen delivery to the patient's body is compromised and the consequences can escalate quickly. That's why understanding respiratory terminology is more than memorizing vocabulary. It gives you the language needed to recognize problems and communicate clearly with other healthcare professionals and make sound clinical decisions when a patient's inability to breathe is on the line.